2, 3, 4 respiratory failure before you, but I want to highlight that gradually this condition has become one of the number one causes for ICU admissions. In the 20th edition of Harrison, 21st would be coming very soon in the next year. In the 20th edition of Harrison is written one of the important causes of ICU admission is acute kidney injury, and after that was written respiratory failure. Well, due to the increased incidence of COVID-19 pneumonia cases, now our ICUs were full all over the world, in fact, with respiratory failure patients mainly. So now this will obviously become number one. Let us focus on the various types of respiratory failure. I will deliberately start in a reverse fashion. I will talk about type 4 because 1 and 2 is what we usually tend to read. So let's focus on type 4 first. You see, type 4 is primarily because of less blood supply, under perfusion of respiratory muscles. And when I say this, I want you to be very, very clear that if I say respiratory muscle paralysis, you see, when you are reading the questions and there's a pressure cooker situation, obviously the interpretations can go wrong. And I've seen lots of guys actually messing up between type 2 and type 4 respiratory failure. The mess up is because in type 2, there is a paralysis of respiratory muscles. But look what I wrote here. I wrote that in caps to actually emphasize that there's no paralysis. There is less blood supply of the respiratory muscles. On this, the query of most doctors is why is that so? So obviously the invariable cause for this would be shock. It could be any variety of shock. It could be distributive, hypovolemic, cardiogenic shock. And the bad news is that in any variety of shock, because the blood supply to vital organs is affected, even the respiratory muscle blood supply is compromised. I would like to specially point out to cardiogenic shock as one of the important causes for type 4, though any of the varieties of shock will cause it. Why? Because cardiogenic shock, there is double insult to the lung. What I mean by double insult is obviously because cardiac contractility is hampered. So there would be pooling of blood in the alveoli, there would be pulmonary edema, but because you're focusing on the word shock as well, so there would be decrease in blood supply not only to important organs of the body, but there would be decrease in nutrition supply, blood supply to even the respiratory muscles. And therefore in cardiogenic shock, you not only have a pulmonary edema component causing a hypoxia, but the double insult is respiratory muscles are also not getting proper supply, so they won't work. And that explains why in type 4 respiratory failure, you need to electively intubate the patient once the oxygen saturation begins to fall to dramatically low values, and you will have to put the person on positive pressure ventilation. Simultaneously, you will also have to treat the etiology of shock in the patient, whatever be the variety. Like suppose it is going to be cardiogenic shock, then there are multiple etiologies for cardiogenic shock that I have discussed in the cardiology section. Like I've told that if it is medically refractory, we might have to use a version of intra-aortic balloon pump that is now called as Impella, or we might have to use inotropes also. Inotropes would be like norepinephrine or dobutamine. That will definitely do a lot of good to this patient. So the main highlight of type 4 respiratory failure is that the blood supply is compromised and not there, and there is not any diaphragmatic paralysis. If he says the word diaphragmatic paralysis, respiratory muscle paralysis, it's type 2 respiratory failure. Let us now compare this with type 3 respiratory failure, which is again frequently asked. Let us see the reasons why. This person has undergone surgery, but the bad news is post-operatively he could not be discharged as planned. Why? Because this person has developed a perioperative atelectasis. You will notice this will be relatively more common in obese patients. This will be more common in old age patients. You see, whenever a surgery is done under general anesthesia, the functional residual capacity, which is the sum of expiratory reserve volume and residual volume, is anyway less. Therefore, there will be a collapse. The message is in type 3 respiratory failure, there will be a collapse of the basal lung segments. And once that happens, then the oxygen saturation post-operatively will be relatively lesser, and this will affect not only the reputation of a surgeon in a sense that relatives will say, sir, you said patient will be discharged by second day, third day after surgery. Now it's taking 4-5 days or sometimes even longer. And it will also add up to the hospitalization cost. It will add up to the direct and the indirect cost. Like even the relatives will have to take some off from their work because they thought that, okay, my dad is undergoing a surgery, so I'll have to stay in the hospital with my dad for 4 days, 5 days. Now he's having to extend his leave. So the problem here is in type 3 respiratory failure, apart from the economic issues, you will have to definitely manage it at a war footing. And it's always advisable that whenever a person is undergoing any kind of abdominal surgery or chest surgery, like a coronary artery bypass grafting, laparotomy, open cholecystectomy, then these patients should actually be counseled to do chest muscle exercise or respiratory muscle exercise, and you can depute a physiotherapist even before the surgery is scheduled for a patient, like 1 week before surgery or 2 weeks before surgery only. If you depute a respiratory physiologist or a physiotherapist to a person so that he can exercise his chest muscles, and I don't mean very severe exercise, just a few breathing exercises if are taught to a patient and he exercises his muscles, then at least the muscles will be in top shape and the chances of type 3 respiratory failure will be minimized. Why I'm saying that is also because you see younger patients after any kind of surgery recover faster as compared to older patients. What is the difference? Obviously, the age. With age, the muscles tend to become relatively lax. The muscles tone basically reduces, and that's for all muscles in the body, including the respiratory muscles also. So, apart from supplemental oxygen, you will have to definitely depute a chest physiotherapist for this person post-operative. Minimize the chances, we can also use incentive spirometry. Lots of time you would have seen that in our patients, especially in the CTVS department, once he's undergone a CABG, a coronary artery bypass grafting, incentive spirometer is provided to the patient. In that, there would be three balls of colors like red and orange and green, and the patient is supposed to blow into the mouthpiece. So when he will blow into the mouthpiece and when the balls will rise, that basically explains the fact that he's exercising his chest muscles. So when it comes to type 3 respiratory failure, I want you to remember especially the aspect of perioperative atelectasis, and the incidence is more in old age and in obese individuals. We will now compare this with type 1 and type 2 respiratory failure. This I will compare simultaneously because mostly in the exam you would be getting except based questions if type 1 and type 2 respiratory failure is asked. The bottom line is that in type 1 and type 2 respiratory failure, both PO2 will definitely be less, but the values of partial pressure of carbon dioxide will either be normal or will be lesser. Why? Because person is hyperventilating. In contrast, when it comes to type 2 respiratory failure, what happens is because there's either a diaphragmatic paralysis or there's going to be hypoventilation. So the carbon dioxide values will spike and there would be even a carbon dioxide narcosis. Let's have some baseline examples. If a person who is, let me say, is a child, he walked into a basement that was closed for a substantial long duration. Now, when a child goes to play in a basement, he will inhale dust mites, etc. So the end result would be acute exacerbation of asthma. In fact, in some cases, the asthma exacerbation can be so bad that the child can go into status asthmaticus. Now, status asthmaticus term per se has been removed from medical literature, so I've written the word severe acute asthma, where you can focus on the word silent chest. You see, the airways will close, the chest is silent. If air is not going to go in, carbon dioxide cannot come out, and therefore the carbon dioxide values in the body will begin to rise. The next cause, an important one from the exam perspective, is ARDS, acute respiratory distress syndrome. Please remember that, like, let me give an example of COVID-19 pneumonia patient. This patient was initially treated with high flow oxygen, no improvement. You put him on NIV, no improvement. So you decided to intubate this guy. You see, initially in ARDS, because there is going to be hyperventilation occurring. So it is a presentation of type 1 respiratory failure. But suppose there's no ventilator available, then the muscles of respiration will get fatigued. And once the muscles will undergo fatigue, then they're not going to be performing. Then carbon dioxide values will rise. So in ARDS, in the later stages of the illness, there can be type 2. But what is the presentation of the disease? Presentation is hyperventilation, that is type 1 respiratory failure. I get a lot of queries regarding it that, sir, in ARDS you have mentioned carbon dioxide can be elevated. Yes, that is in the later stages when treatment is not given. But what is the presentation? Presentation is type 1 respiratory failure. In fact, for the two examples that I'm now writing before you, ARDS and CHF, you very well know ARDS is non-cardiogenic pulmonary edema. Congestive heart failure can occur after anterior wall MI. The word I wanted to remember here is alveolar flooding. The surface area for, if there's going to be fluid in the alveoli, the surface area for gas exchange will be hampered, which will explain why there is a hypoxia, and therefore the person will try to breathe faster also. So carbon dioxide values will also become relatively lesser. Another example I want you to remember here happens to be fat embolism. Like this guy, he is driving a heavy duty bike and the bike fell on his leg and he has had a fracture of the long bone. Now, after 48 hours, the fat globules have resulted in cytokine production, which is contributing to ventilation perfusion imbalance that triggers hypoxia and causes type 1 respiratory failure. Whether it is a routine case of COVID-19 pneumonia or it's a community acquired pneumonia caused by pneumococcus, hyperventilation is the norm, and so would be a COPD patient in whom a bulla has burst, resulting in a complication called as spontaneous pneumothorax. These are the usual causes of type 1 respiratory failure, and the logic to be used by you to answer whether it is type 1 and type 2 is in type 1 there will be a hyperventilation. Whereas in type 2 respiratory failure, there will be hypoventilation or there will be a diaphragmatic paralysis. Majority of times when the questions of type 2 respiratory failure have been asked in the exam, he has deliberately put up neurological causes. You see, conditions where I have discussed diaphragmatic paralysis can be like Guillain-Barré syndrome, transverse myelitis. Pediatric examples can be like polio, or in case of a home delivery, honey was given to the baby, so botulism can also contribute to this. Then I'm describing case of let me say the guy who used to play Superman, Christopher Reeves, right? I mean, Superman was actually riding a horse, right? After he retired from movies, he was riding a horse and he fell from the horse and he broke his neck at C3, C5, and diaphragmatic muscle paralysis will definitely come in. Or I can give example of gymnastics. In gymnastics, all these young boys and girls do so many somersaults. Now, when you're doing a somersault and suppose it goes wrong and person lies, falls on the neck, the cervical spine can break, and the bad news would be type 2 respiratory failure. Person will become wheelchair bound for whole of their life. Let us just summarize the 4 types of respiratory failure that I have explained to you. If you just focus on the core issues, you will be able to get questions raised on this topic. For type 1 respiratory failure, I mainly want you to remember 2 examples of alveolar flooding, that is ARDS, and congestive heart failure. And for management of these patients, you will have to provide the person first, obviously, a non-invasive ventilation. But especially in ARDS, we do not go ahead with a routine ventilation in a sense that the tidal volume settings are kept on the lower side. The logic is like in COVID-19 pneumonia, already there is damage to the alveoli. If you will keep normal tidal volumes, you will introduce barotrauma in the lungs of the patient. So it is low volume ventilation. Along with this, I've also talked about prone positioning of the patient, neuromuscular blockade to be done. So all the aspects of ARDS are obviously to be studied. But the keyword for type 1 respiratory failure, because ARDS is one of the important examples, is low volume ventilation. For type 2, I want you to remember 2 examples primarily. One is a person of severe acute asthma, formerly called as status asthmaticus, and then can be acute exacerbation. AE would mean acute exacerbation of chronic bronchitis developing in an individual. This is a COPD patient which has deteriorated very fast. In type 2 respiratory failure, we need to provide the person non-invasive ventilation. This would be with help of a tight-fitting face mask, and our objective would be to keep the SpO2 of this particular person more than 90%. Once you put in a tight-fitting face mask, it looks very easy, but you would have seen the claustrophobic look on the face of patients with COVID-19 in which you have used non-invasive ventilation. When it comes to type 3 respiratory failure, I personally find this easiest to remember and least errors are found in people answering type 3 respiratory failure where there's a perioperative atelectasis. You would obviously be providing oxygen to these patients subsequently. And as I highlighted, chest physiotherapy initiated as early as possible, especially in patients who are frail, who are fragile, and are having decreased muscle tone. I would suggest that the physiotherapy component to be started as early as possible. I have already sensitized you to the fact that if it's gonna be respiratory muscle paralysis, like in Guillain-Barré syndrome, it is type 2, but there is underperfusion of respiratory muscles, which is secondary to shock, like hypovolemic shock, distributive or cardiogenic shock, then it's gonna be elective intubation and positive pressure